managing the PICU now in Mehta Hospital. Over to Dr. Sasidharan.
Thank you, sir. Thank you for kind introduction. So actually, it's always mutual, sir. We are learning beyond pediatrics many things from you. And we always consider this as the greatest opportunity in life to see and work with you. You have always been inspiring to one and all who have been looking at you as well, working with you. So thanks to IAP Tamil Nadu State Chapter and Dr. Rajendran sir for motivating us to conceive this idea of critical care CME. I'll go directly to the topic of discussion. So after Karti's mesmerizing presentation, it's very difficult for the for me to catch you hold up for next 40 minutes and enjoy the talk, but I'll try to do my level best. This is a very interesting topic nowadays because we are going to discuss about pneumonia and we are going to discuss about non-COVID pneumonia in the COVID era, which looks quite interesting, no? So viral pneumonia in children, how to manage in COVID era. So the preamble is COVIDology in adults and pediatrics. We know that it is significantly different because the manifestations are quite different. How much different? In an adult, any pneumonia is considered to be COVID pneumonia unless otherwise proven. But even in the COVID era, it was not the same scenario in children. And I strongly consider that it should be called as post-COVID era. So now it's clearly not the same. So non-COVID viral etiology pneumonia is most commonly seen, at least in last 2 months in this part of the country. COVID requiring hospitalization in children, predominantly MISC. We hope that it will remain so. COVID seropositive state and MISC are not same, and it has been alluded to in at least 3 presentations in the 3 previous presentations, including Mulay Balaji's presentation. It was reiterated by Professor SBS, and Karti also touched upon the same issue. So we are not going into that. Though epidemiologists predicted 3rd wave COVID in children, it's good that it has not started, and we hope that it won't be encountered. What is the current concern? In this scenario, what is going to be the current concern? The non-COVID viral pneumonia in children. This has already become a major concern. And at least in Chennai and peripheries of Chennai, we know that everyone is seeing the non-COVID viral pneumonia in quite a significant proportion in outpatient as well inpatient practice. So in next 30 minutes, I'll try to discuss next 20 minutes on trying to answer 4 questions. Viral pneumonia, is it a real concern in Indian children? Viral versus bacterial pneumonia, what's the current understanding? What is useful for the clinical application? COVID versus non-COVID viral pneumonia, why a specific concern in children, and how to approach viral pneumonia in COVID era. And the last part is next to 10 minutes, I would try to, that is 20 to 30 minutes. So I will try to discuss about the protocolized approach and respiratory support using some case scenarios. Viral pneumonia, is it a real concern in children, especially in India? What the other data says, under 5 children requiring hospitalization, viral pneumonia is not uncommon, including in India. Viral pneumonia is not uncommon. That is to an extent we started understanding now. We do not question that anymore. Viral isolated nasopharyngeal swab not always equate to infection. We are sending a nasopharyngeal swab. We are finding a rhinovirus positivity or adenovirus positivity. Can we always say that it is a rhinovirus pneumonia, adenovirus pneumonia? It's not the case, because there is a strong evidence to say that it can be just a colonization. Host symptoms help in diagnosis. So how do we interpret? We are sending a nasopharyngeal RT-PCR test, and it is showing a H1N1 positivity or influenza A positivity or influenza B positivity or RSV type B positivity or metapneumovirus positivity. The child is symptomatic enough to an extent to get admission into PICU. The child is on oxygen support. So we do not discard it. We call it as a viral pneumonia, and we consider that as a strong evidence of infection. So viral isolate doesn't equate isolated viral infection. The mixed infections are possible. Please be very much aware. Viral doesn't mean that you are ruling out bacterial. Viral plus bacterial doesn't mean that you are ruling out coexisting fungal or superadded fungal. So Initially, we thought that these conditions are common only in immunocompromised children. Immunocompetent children, mixed infections are uncommon. This has been proven repeatedly false. And when we start doing a combined panel PCR, we start understanding the truth is other way around. So even immunocompetent patients, if they are presenting very sick, especially with prolonged period of ailment, maybe more than 7 days, and they are pre-treated outside, they are treated for 7 days, 8 days, 10 days, not responding great, mixed infections are quite possible. 55 to 66% of pathogenic organism in under 5 pneumonia, as per the CDC data, is viral isolate. So we can't ignore this, and we can't repeatedly say that in developing countries still bacterial pneumonia is the commonest. So significant proportion may be a viral pneumonia or a coexisting viral infection. Individualize your treatment strategy based on the response to therapy. That is what currently we have to offer to the patient. So now we go to the next question. So we understood that viral pneumonia is common even in India. In our circumstances, every day we are encountering. So understanding is quite important. Now the second question is viral versus bacterial pneumonia. What is the current understanding? Whenever we say viral versus bacterial, we are critically claiming that the binary differentiation is possible. Just now I told that the binary differentiation may not be possible in critically ill children. Keeping that in mind, we will try clinically what differentiation is reasonably possible to make and which can reasonably help us in managing these children better. Viral versus bacterial pneumonia, the important add-on in your toolbox of investigations is this combined viral bacterial pan-fungal multiplex PCR panel. It is quite attractive. You send the sample, it is an easy sample, nasopharyngeal sample. You have a clinically sick presenting child, so it makes it meaningful to send the sample. You get the report within 8 to 12 hours and you have the diagnosis in hand. You can titrate your antibiotics. Everything is possible, but the cost is quite limiting. So when the cost is quite limiting, what is advisable, at least in the sicker patients, where the trajectory of clinical disease is going unpredictable, or the anticipatory guidelines say that the child may require invasive ventilation, maybe within an hour or so, or within next 6 hours, then at least in those children, it gets a merit. These children get some merit to get evaluated with the combined viral bacterial pan-fungal multiplex PCR if possible. Identify mixed disease pattern yearly. The yearly identification really ensures the best outcome. How we say that? We all know that whenever we say viral pneumonia, usually in a immunocompetent child, we are concentrating on under 5 age group. If you can divide it into under 24 months, where you call it as bronchiolitis. Beyond that, we call a conglomerate terminology of viral pneumonia. So we all know that it is predominantly airway disease to start with. It is a high resistance lung. Obstructive airway pattern is the predominant pattern of disease. But when the disease has become prolonged disease during the natural history, the trajectory is not showing a recovering trajectory. The trajectory is showing a worsening or progressive trajectory. Then the possibility of having an additional lung tissue disease is quite common. So whenever the component of additional lung tissue disease happens, this is called a mixed lung disease, which is really difficult to handle. And this may eventually evolve into attributing to the in-hospital mortality risk. So these patients, the evaluation has to be very comprehensive, and the early identification is quite important. So after saying so, I already alluded that the investigation, which is quite attractive, is being so costly. It can be done only for a selective subgroup of population, even in PICU. So doing this in ward and ER becoming remotely imaginable, at least in the current scenario. So what we are supposed to do is we have to have some clinical risk factor in hand to identify whether it is highly likely to be bacterial or viral. High-grade fever spikes, clinical features of toxicity, multi-system involvement, focal lung involvement, pleuropulmonary disease pattern, all these things may help you to differentiate viral versus bacterial. Focal lung involvement, highly likely to be bacterial. Multisystem involvement, it can be bacterial, but you can't forget about H1N1 disseminated disease of any viral etiology. And high-grade fever spikes are usually uncommon in viral pneumonia. Pleuropulmonary disease, this is very important. A child with community-acquired pneumonia evolving to have something like a pleural effusion or empyema, which is quite common with invasive pneumococcal disease or a staph lung disease. Bronchopulmonary disease. Bronchopulmonary disease is predominantly more common in viral disease. So these kind of differentiations are clinically still possible. Now we have to understand another very important component. Whenever we speak about pneumonia, does it always going to be a single system disease we are going to encounter in ICU? That's not the case because of two reasons. One is the same viruses which are causing a respiratory ailment may have an extrapulmonary manifestation, which is an extrapulmonary manifestation of a primary viral disease, which is a lung-specific viral. For example, RSV infection may have some extra pulmonary manifestation. That can be a viral myocarditis. It can be some OTPT rise and transaminatus. So those things are quite possible. So we have to consider that also. What we are going to discuss here is a little different. So more than one system involvement, that is called a pre-existing or a coexisting disease. Understanding this is very, very important to design our therapy accordingly. For example, the primary cause respiratory, that is a community-acquired pneumonia, along with myocarditis is possible. So in a child who's having a left run shunt lesion like VSD, having a community-acquired pneumonia, make it as a more than two system involvement. CNS disease of encephalopathy may have a community-acquired pneumonia component. Along with the poor worsening sensorium, they can have an add-on aspiration component causing pneumonia worsening. A respiratory presentation of CAP can happen in a neurometabolic disease child who is a predisposed or a child with a pre-existing illness. A child with community-acquired pneumonia, especially an organism like adeno in an immunocompromised child or a post-bone marrow transplant or a post-transplant solid organ transplant scenario, they can present with the sepsis and septic encephalopathy or disseminated adenoviral disease. So all these things are quite possible, and we have to think beyond based on the predisposition in the index patient. This is very, very important. What are all the diagnostic studies available? Chest X-ray, it's a very commonly done one, not routinely indicated, but in sick children, when we discuss, this is mostly done. And it will give hyperinflation and segmental atelectasis as you're finding if it is a predominantly viral disease. Complete blood count has not been very specific. CRP do not discriminate bacterial versus viral, but the trends may help you to differentiate to an extent. Nasopharyngeal swab is helpful in cohorting the admitted patients, and it helps to understand the local epidemiology. Sometimes it helps to titrate your therapy as well. Blood gas analysis is reserved for potentially respiratory failure patients or assessing the respiratory functional status. Blood culture needed in less than 2 months old babies. There is no doubt about it. 2 to 6 months also may need, but beyond that, one-to-one basis, we have to decide. Echocardiography may be required in those who's requiring non-invasive or high-flow support. It's mostly based on the unit protocol. For example, in our protocol, whomever goes for HFNC will get at least a screening echo done. Procal may be useful to decide antibiotic therapy, and predominantly it is useful while you are de-escalating your antibiotic. How do we identify severity of viral community-acquired pneumonia? It is a very simple thing which we learn from PALS. And I am highlighting only two things here: saturation 90 to 95%, along with increased respiratory effort and tachycardia. It has to be classified at least a moderate level of distress. Severe, very well, markedly increased respiratory rate with the chest wall retraction, nasal flare, and grunting. Saturation falling less than 90%, which is mandating 100% hospitalization and high dependency or ICU care. So can we estimate everything only based on this? No, we need some adjunctive measures to guide the respiratory support therapy. That can be a chronicity or acuity of illness, that's disease duration, work of breathing, response to therapy, past episodes of similar illness, hemodynamics and other organ function status, arterial blood gas, and microcirculatory assessment. With the aid of this, we would be able to decide what amount of support is required. So now the next question to be answered is COVID versus non-COVID viral pneumonia. Why we need to differentiate and what is a specific concern associated with this? That's what we have to answer. So COVIDology, as we told, in adults and pediatrics, there was a significant difference. Luckily, COVID pneumonia is not common in children. COVID seropositive state with the viral pneumonia is not uncommon. That is very important. It is not uncommon to have a COVID seropositive child presenting with viral pneumonia. How a non-COVID pneumonia evolves in a COVID seropositive child, it is still unanswered. Maybe we will be getting better answers over time. So currently, the major question before us is COVID seropositive state, does it influence the disease trajectory of other viral pneumonia? So as of now, we do not have any answers. Maybe maybe within a few months, we may be having some preliminary data to understand that, because we have already faced the first episode of the significant number of non-COVID viral pneumonia in children. So once the data is analyzed, we may be having the better idea. So understanding the difference between COVID versus non-COVID viral pneumonia, so we have to decide how to approach viral pneumonia in the COVID era. So we all know that the COVID exposure and serology, whatever we say, we are not able to interpret. Interpretation is not easy. All COVID seropositive is not MISC. COVID pneumonia is not very bad in children. Everything we understand, but as of now, it is very difficult to discard the COVID seropositive state. So in that scenario, how do we approach this children presenting with viral pneumonia? So what happens is COVID exposure can be an asymptomatic or self-resolving fever or just a community exposure. So we, after some weeks, or now we are getting patients after months also having some respiratory symptoms, wheeze, respiratory distress, chest X-ray evidence of pneumonia. So in these children, when we do COVID antibody test, I am not very sure how commonly we do COVID antibody test for all these children, but at least in our unit where I practice into 3 centers, we do COVID antibody as of now commonly for all these children. So most of these children are coming COVID antibody positive, which is strongly positive. You cannot ignore that extent positive. And they are all coming to a reasonable extent COVID PCR negative. So they are not in the active COVID infection phase. So here, the problem is we are seeing more and more of non-COVID viral pneumonia. So non-COVID viral pneumonia is what we have seen till now. Maybe we would have already had close to 40 patients who have been admitted with all these RSV infection, which is the most common now, influenza and parainfluenza, metapneumovirus infection, streptopneumonia as a co-infection with RSV positivity as well parainfluenza positivity or H influenza or influenza positivity, Klebsiella pneumonia as a co-infection. The spectrum may grow further. So what happened because of this? Our investigation panel has increased. Obviously, all these have reflected in the cost of therapy. COVID RT-PCR we have to do for all COVID. Our serology we are doing, CRP, LFT, and RFT we are doing. Blood culture we are doing. Respiratory panel PCR, that's the combined panel PCR we are doing for all. But how it is helping us is we can titrate the therapy as early as possible, and we are able to reduce the duration of stay in ICU. So most of these patients, the only good thing is, though we are spending too much on the day one, we are able to see that even the sicker ones who are presenting on day one are able to leave the PICU successfully, transition to the ward within 4 or 5 days. So that is the one thing which is encouraging us to continue to do this kind of investigation. Now we have to come to the protocolized approach, and respiratory support in hospitalized kids. So we have to understand all these things, just because the major reason behind this, we have to create an approach which can be implemented in in reality. So this approach is a old respiratory support escalation approach. Reasonably, to an extent, it remains the same. I am concentrating on a patient suspected to be presenting with a viral pneumonia. So tachypnea, we are using any kind of scale. What we use have been given here. So as per your tachypnea scale, the child has been graded as tachypnic, and saturation is less than 94%, increased work of breathing, and signs of poor perfusion. So if any one of these critical features, they are not maintainable airway, not improving perfusion, hypotensive shock, primary disease contraindication to NIV, the child is going to get intubated and invasively ventilated. If these critical issues are not there, the child is progressing to the next step of screening, that is starting the oxygen support. If the child is maintaining with the simple face mask or SFNC, you can continue on the SFNC. And the initial 1 hour for a child who is having a viral pneumonia, the predominant symptomatology is going to be a wheeze with or without diffuse crackles. So you will be giving trial nebulization therapy, 3 doses of back-to-back as per your unit protocol, the mix of bronchodilators, other ABC stabilization measures as per the conventional approach. After the 1 hour nebulization support, if you feel that the child is not getting stabilized to go for a ambulatory management, you are going to do a support escalation and admitting the child. That's what is going to happen. And the support escalation is going to be an immediate advanced airway if needed. Again, you go to this critical screening. If any of these is there, you will proceed to intubation and invasive ventilation. Otherwise, if there are no contraindications, simple flow response is poor, indications for continued oxygen support is there, then you can escalate the to trial of high flow and shift the child to high dependency unit. So in this children, if you have a high flow responsive state for a simple understanding, you have to have a reasonable response, means CO2 should not increase, the child's sensorium should not worsen, CO2 should not creep up, and the FiO2 in the HFNC, you should be able to come down at least to 50 or 60% within 4 to 6 hours. If these are there, it is worth continuing the HFNC support. Otherwise, the HFNC support may be inadequate. You have to consider to next level of support. When you are giving non-invasive respiratory support, you are not going to give only non-invasive respiratory support. You are going to give some adjunctive therapies based on the severity of the child. You may be giving inhalational bronchodilators, intravenous bronchodilators if the child is very sick, chest physiotherapy and positioning, high flow oxygen therapy, antiviral medications, steroids, not in all children, but maybe some rescue steroids in a severe distress impending respiratory failure, IVIG based on the unit protocol. These things may also serve as a adjunctive therapy. One important thing we need to understand, that's the only reason why I put the slide. The only thing we need to understand is non-invasive respiratory support therapy is always to avoid ventilation support. It is not to delay the ventilation support. It's very, very important to understand. So early identification of non-invasive support failure is a crucial step for better outcome. So you have to establish stringent guidelines to diagnose NIV failure early. So any of these blue things are there in a patient: signs of increasing work of breathing, poor gas exchange, hemodynamic instability, signs of respiratory fatigue, change in mental status, worsening PF ratio, or keeping up of metabolic acidosis, CO2 remains high. So any of these patients, any of these signs are present in the patient, maybe your patient requires the support escalation. There is no point in just continuing on high flow. This is a very crucial thing because it influences the outcome. So now we have discussed about grossly what are all the things available and what we are going to do. Now I just try to explain this using 2 case scenarios. So yes, is a 2-month-old male child, cough for 2 days, respiratory distress for 1 day, reduced activity, refusal of feeds for 1 day duration, received syrup cefixime for 2 days on OPD basis. Birth and antenatal history remained uneventful. So this is the X-ray of the child. And what has happened? We have admitted the child, started on IV augmentin and syrup oseltamivir. Respiratory distress was there. To an extent, the child has got SFNC2 escalated to high flow. 9 liters per minute, 45% FiO2. The child was looking as if responding to high flow, but the fever spikes are persisting, high-grade fever spikes. So here we have, because of the persistent respiratory distress in bees, we ended up in giving IV Maxel 50 milligram per kg, Q6 hourly. We give maximum 4 doses and stop. That's what happened in this child also. So this child, for sedation, we have started on IV dexmedetomidine infusion. This is the standard dose we use, 0.4 to 0.6 microgram per kg per hour in our unit. The biggest advantage with this is like it reduces the heart rate a little bit. It may be very helpful in bronchiolitis children, and this is not having a huge residual effect. That's an advantage. At the same time, the bolus dose of 1 to 2 mics per kg we do not give, and we always have a fear of hypotension or bradypnea or extreme bradycardia with the high doses, so that we have to be very careful with. After around 48 hours, the child, 24 hours, the child has been started on trophic feeds by nasoduodenal trophic feeds, thus as per our unit protocol in HFNC children. At 48 hours, the child status is screening echo showing ejection fraction of 77%, hemodynamically insignificant PFO. Nasopharyngeal swab report has come as RSV positive. Fever is still persisting, worsening respiratory distress, and episodes of bronchospasm, which is not an unusual course. So here the respiratory distress is worsening. So on HFNC, we are continuing on HFNC. In that, because the RSV came positive, we have given a polyclonal IV immunoglobulin 1 gram per kg over 24 hours. Terbutaline infusion has been started because we had a little bit of difficulty in this child in delivering the nebulization properly when the child is on HFNC. So HFNC system is very familiar to you all. We are not going to, through the details of this. It has an oxygen input, and based on which titration we will get some FiO2. And this is the total flow. Do not think that this total 30 liter which is showing is completely oxygen. It is mix of oxygen and air, and this is the temperature. So this is the commonly used system, and whenever you are using high flow system, the most important thing to concentrate is selecting an appropriate interface. We call it as OptiFlow cannula. So there is a guide sheet which is available. So based on your flow and nasal size of, or nasal orifice size of the child, please select the appropriate size tube. Otherwise, the kinking and blocking and inappropriate delivery, or the stream of flow becoming laminar to turbulent, all these things are quite common. So you may not be able to efficiently provide the HFNC support, though the patient is attached to high flow. So those circumstances have to be avoided. So why HFNC in viral pneumonia or under 12 months or under 24 months bronchiolitis is quite important, and it looks as if it is saving lives. It has a very specific mechanism of action. So it avoids the mucosal injury by heating and humidification, and gives a better clearance source for secretions, higher gas flow than the inspiratory respiratory demand. So this will help in washing out the nasopharyngeal dead space. It decreases the nasal resistance, and it enriches the oxygen admixture in nasopharynx. So though it is a flow dependent system, which is not providing a consistently standard PEEP throughout, this is quite helpful in reducing the respiratory work of breathing. So sedation practices, this is very, very important component. Always the question is whether to use or not to use, but only thing which you need to go through is you have to understand the goals of sedation. So it is just to reduce the anxiety and better comfort. Look for the negative effects, hemodynamic stability, respiratory depression. These should be avoided. This is very, very important. Sorry. Sedation practices in HFNC or NIV support, what we consistently do, this is what we need to spend some time on. Dexmedetomidine is very commonly used. The bolus dose is 1 microgram per kg. But as I've already told, bolus dose has some issues. That's why we try to give the infusion dose starting from 0.2 maximum 0.6, it is reasonably safe. Few units prefer to use midazolam. So midazolam can be used from 0.05 to 0.1 milligram per kg, which is given here. So or 0.5 to 1 to 1.5 microgram per kg. So either dose based on your unit protocol you can use. NIV and HFNC sedation practices is not based on published evidence. It is based on predominantly your unit protocols. Is there a way to predict HFNC failure? So whenever we are using high flow, we just want to understand whether we can predict the failure easily by some scoring card. Most of the effort which have been put are not very much useful on clinical circumstances. This is what we need to understand. But if the PRISM score is quite high, or the lower respiratory rate with CO2 at initiation, the lack of decrease in respiratory rate after the therapy initiation may give some guidance towards probable failure. And another very interesting component, which doesn't have a huge evidence in pediatric population, which has a very reasonable evidence in adult population, is using the ROX index. ROX index is a ratio between SF ratio to SF2 respiratory rate. So now here there are 2-3 numbers which are standardized based on the adult data. So more than 4.88, there is a less probability of endotracheal intubation and mechanical ventilation. But the basic issue is it has not been well validated in children or children with bronchiolitis. So that is why using ROX index alone may not be very useful, but it is good to say that more than or equal to 4.88 may considerably say that patient may not get intubated. So I'll show few things which may be of very significant clinical use. So the one thing is how to deliver nebulization in HFNC. So the inline nebulization in HFNC, whenever we start high flow for a viral pneumonia child, always there is another question. So how do we deliver efficiently nebulization from this point time onwards? So it is a very reasonable question. Just to come out of that, so these kind of devices are now available. So this is a Aerogen neb set, which has a connector, nebulization connector. After the OptiFlow cannula, before the breathing circuit connection, you can put a T connection and connect it with the Aerogen nebulization set, and you can provide a good amount of nebulization. This is quite possible nowadays. And this is the way it looks. So there is a T-piece connection, and there is another straight connector which is directly connecting to the neb set. So if you do not have that specific Aerogen ventilation or inline nebulization set, the routine nebulizer can be used using the same connector, because this connector connects directly to your nebulization set. So this is also possible. But only problem what we encounter is by connecting near the OptiFlow cannula end, the condensation and trickling of water at the nasal end and blockage may be more common. So you have to be very careful. So now this is almost kind of like it is a very great help. So now we can, the newer circuits which is available for high flow, you can connect to the humidifier itself, the nebulization set on the wet side. So the advantage is you do not cause too much of condensation or difficulty in the flow delivery or conversion of laminar to a turbulent flow. So those disadvantages are not there. So we have to be very careful about the way in which we deliver the therapy. Steroids in bronchiolitis. It's a very important question, but current any guidelines say that systemic corticosteroids are not recommended, and inhaled corticosteroids are not evaluated and are not recommended. The data from our unit, we have compared 100 children with viral pneumonia, where 57 received systemic steroid rescue therapy. The systemic steroid rescue therapy, what we have used at that moment of time is dexamethasone, 0.6 milligram per kg day 1 and day 2, and then 0.3 day 4, and 0.15 day 5, and 0.15 on day 4, and stop. So this is only for 4 days. and the maximum ceiling dose is 4 milligram. So in these, this thing, we can just say that it's a cohort comparison, no difference in length of stay or length of oxygen support in either group. But the good thing and reassuring thing is there is no difference in bacterial infection or readmission rate. So the complications, especially because of the steroids, were reasonably less when you strictly follow the HIC principles and you try take an extra step to avoid the secondary infections. But at the same time, whether it reduces the length of stay or length of oxygen therapy, actually the available answer is no. So intravenous bronchodilators, you know that IV magnesium sulfate is commonly used, though the evidence for that is not very clean and robust. So if you are using more than 2 or 3 doses of Maxelf, it is better to monitor the level. Terbutaline added in severe cases on one-to-one basis, it's very difficult to give any recommendations for its use. So what happened in this child? So we have given IV midazolam after this dexmedetomidine because we want to sedate the child. We remove the dexmedetomidine. We have given midazolam. This happens in many places. And child status on day 5 is respiratory distress settling and episodes of bronchospasm has reduced. Terbutaline stopped and the child has received this DEXA rescue, and HFNC tapered off and switched to simple flow. SFNC went to room air, and the child has improved well and discharged. So the other case, I'll complete in next 3-4 minutes. This is a 7-month-old female child. So a mother noticed the child has sudden unresponsive while feeding with a cyanosed appearance, rushed to nearby hospital. At emergency room, the child was apneic with low saturation and was posturing, intubated and loaded with midazolam, levetiracetam and mannitol. So this is kind of an acute life-threatening event presentation. This child's final physiological categorization is intubated for respiratory failure. Hemodynamically, it is a stable child. The initial measures, the child has been intubated, initiated on ventilator, fosfenitoin loaded, and ceftriaxone IV and oseltamivir empirically has been started. This is the chest X-ray at admission. But once you started ventilation, you will start understanding what could be the probable reason for this acute life-threatening event. What we started understanding in this child is the child didn't have major seizures, what we have expected, but there were bronchospasms. So a nasopharyngeal swab also positive for RSV. The procal was high. Appropriately, the antibiotics have been escalated. The nebulization was the major therapy here. The child received the same injection Maxelf as well IV terbutaline. The exacerbations were quite common in the ventilator. This is what we struggle to manage usually in the obstructive airway disease ventilation. What I wanted to highlight here is nowadays the inline nebulization is very easy. You can provide in a ventilated child. And the repeated X-rays and lung ultrasound monitoring will help you. In this child, there is a right lower lobe and left middle lobe atelectasis after 48 hours of invasive mechanical ventilation. What we have decided to do is we have been giving the aerosol therapy, but it is not helping completely. So we have proceeded with something other than the routine. So this child's blood culture grown streptococcus, IV vancomycin has been added. As you know very well, RSV and influenza pneumonia, if the child grows a pneumococcus, then it means that it is a very detrimental thing. These children may behave very bad. So what we have done extra, what I told, we have done something extra is the exacerbations were slightly better because the atelectasis has been increasing. Now we have taken up for bronchoscopy because the indication was a persistent collapse and high FiO2 requirement. So post bronchoscopy, the child showed a significant improvement, extubated to HFNC, stopped the terbutaline infusion, NEPs have been spaced out, and slowly we have been able to come out of PICU and transition the child to ward, and child is completely normal now. And this is the very important thing, deciding the right time to do bedside bronchoscopy. for lavage in a intubated and ventilated primary airway disease when it is transitioning to the mixed lung disease. This is a very, very important measure which helps in salvaging very critically ill children. So this is pre and post bronchoscopy. You can see that the significant amount of collapse here and which has opened up. And we have a pre and post extubation X-ray. And this is my last two slides. What is the learning points from this case? The second one is the most difficult case. Viral pneumonia can present with apnea. ALT is not uncommon presentation. Goals of invasive mechanical ventilation may become very dynamic based on the predominant airway transitioning to the mixed disease pattern. Mixed lung disease management and role of bronchoscopy has to be understood at least in intensive care unit. 2D echo and lung ultrasound monitoring important in mixed lung disease because you need to identify the transitioning illness, treat the patient and not always chase the blood gas because chasing the CO2 in an intubated bronchiolitis baby is close to impossible. But at the same time, don't allow the CO2 very high, which can compromise your RV function. The take-home message: viral pneumonia in COVID, predominantly what we see, at least this part of the country, is non-COVID spectrum. RSV, metapneumo, influenza are more common. Every day we are having a significant number of patients with this positivity. Use an objective scale to trigger the respiratory support in ER, which will be very useful. Always decide the best respiratory support for the index child based on the expertise and available equipments. Just like what told in Ramesh in his presentation, available and best, most comfortable inotropic agent or vasoactive agent. So what is available to you, and among that, what is comfortable for you, that is the one to be chosen. Nebulization therapy remains an important adjunct to respiratory support. Because you have started HFNC, you can't stop nebulization. Never delay intubation by using NIV. NIV's aim is to avoid intubation. It is not to delay intubation. Continuous monitoring is the key, and mixed infections are very common in sick children. Thank you.
Thank you, Dr. Sasidharan, for a wonderful talk. You very nicely brought out the problems of viral pneumonias using the case scenarios, and of course, the life is full circle. We have come back. I think when we started during DCH 1970, 80 and all, steroid was the only management for bronchiolitis. Steroid, IV freeze and oxygen. I think now slowly coming back. Probably we may need more evidence to concretely say steroid and things are useful. Thank you so much. You have covered a nice new topic in a wonderful way and clarified the background information and the problems caused by viral pneumonias. There is a question for you, Sasi. The question from Dr. Lenin. Recently, I had a 6-month baby, preterm, NICU graduate, not a STROMI course, admitted for respiratory distress, progressive, despite HFNC and supportive management. BAL culture revealed CME strongly positive, VOCA and RSV weakly positive, needed mechanical ventilation with ARDS settings, but no other features of CME infections. So, how to consider